we're going to come up with. And in this very narrow framework, which in some ways strips our agents of many useful aspects of their humanity, and we'll talk about that, if they find out they're HIV positive, have nothing to lose in this model. Again, we'll talk about the limitations. Now, the effects can go in different directions, actually. So even though A is correct in the sense that it could go in this direction, can someone who answered B explain the opposite rationale? Yeah?
Well, it's like the opposite way. Like you find out that you're negative, and you assume that every unsafe sex act leads to HIV, then that will not produce an increase in unsafe sex because they haven't been negative.
Exactly. So what really C is the technically correct answer, but the intuition here is A could be correct and B could be correct based on a couple things. First, we have to know what fraction of people are actually infected. B, we have to know what their perceptions were about how likely they were to be infected before. So in the world where, like some of the surveys I talked about, 30 or 40% of people think they're HIV positive, but really it's 5%. So all these people who thought they were HIV positive, who would kind of be tempted to have this nothing to lose effect anyway in T equals 2, telling them they're negative could tell them, wait a minute, I have something to live for here, let me be safer. But that's going to be counterbalanced by the people who thought they were probably negative or weren't sure, who now find out they're positive. So you're going to have different people's behavior changing in different directions based on what their expectation was, their prior was, and what their actual information is. So it's a very interesting model. And if you're interested in sort of modeling this more precisely, there's a former PhD student of ours here named Eric Gong, who's now a professor at Middlebury College, whose job market paper 2 years ago was that model, and then he worked out in some data. There was some early data testing people in Kenya and Tanzania in urban areas where some individuals were given their test results and others weren't, and then they look at the change in subsequent infection status, like for other STIs, as well as HIV. And he finds some evidence that it can kind of go either way. So the overall effect is going to be the balance of these two effects. So there's a hand up in the back. Yeah. Yeah. Well, of course, yeah. We'll talk about that. That's the clear kind of gap here. So we'll talk about what that does to the model, and that can turn things the other way. An altruism effect is clearly part of the human experience and something we're going to want to model. So we'll come to that. That's I kind of think the big gap in this framework. That said, it's a big gap. We all thought about it, but in the sample from, it was about like 12 years ago now where that data was collected, Eric Gong actually found out that people who thought they were negative and found out they were positive were more likely to engage in unsafe sex over the subsequent year. He found that effect, and it's kind of staggering and shocking, but so there's something to this nothing to lose effect. At the same time, many people will have very strong altruistic tendencies. So we'll talk about that trade-off in the model in a second. Do you have a comment? Well, some people who engage in unsafe sex don't become positive in reality. So they may fear because they knew they had unsafe sex that one time or those 5 times or whatever it is, they may fear they're positive, even if they're negative. And especially given some of the public health messaging early on in the epidemic, which I think honestly exaggerated the risk in the sense of like, try to make people feel like one unsafe sex act could kill them, which it could, but it's very unlikely it would. Then a lot of people thought they were infected when they weren't. So I think that's the population that might benefit from information. Okay, so let's go through this issue, and what we're going to do effectively here, I talked about these 3 periods, but I'm going to cut it short and sort of start with that period 2. So there's some pre-existing period 1 in which you might have gotten infected. Now you're making your safe sex decision, and you have today, your youth and your old age, but you have some belief. You think your likelihood of being infected is this variable R, which is between 0 and 1. Now, therefore, if I engage in safe sex, and I think I may already be infected, so with likelihood R, I'm already infected, so I'm only going to live to old age with probability P HIV. With probability 1 minus R, I'm uninfected, and I'll live to old age with probability P, and all that is multiplied by the value of life. So this is just the algebra, here. And if you go through this, now my expected utility, so R is a really key new factor here. So that's the expected utility of safe sex. Unsafe sex is still the same, because we're going to assume here, again for simplicity, that if I engage in unsafe sex now, I believe I'm going to get infected. So I understand, if you think about this clearly, there's a little inconsistency between the formulation, but the algebra is straightforward. I think the intuition is the same. What does this mean for the difference between unsafe sex and safe sex? Now it's a little more interesting and complicated. There's still the benefits of unsafe sex, whatever they are. But now it's not just a question of the objective change in the probability of living to old age that matters. My perception of my status matters a lot. So if R equals 1, I'm sure I'm infected. And I'm back in this world of the nothing to lose effect here, because we haven't brought altruism in yet, which we will. If I think R equals 0, I'm back in the previous model, where I'm doing this trade-off. Oh, if I'm safe, I'll be healthy. But maybe I want to be unsafe. Maybe I want to take that risk. And then there's people all the way in between. It could be 0.5, it could be 0.3, it could be 0.7. And those people are going to make different decisions about risky sex. But the thing in this very simple framework is the more likely I am to think I'm infected, the more likely I am to just sort of give up on things and say, well, I'm already infected. And this, of course, these people are jerks because they're infecting other people, right? So we'll talk about that. Okay, this is the nothing to lose effect that everybody, a bunch of you have the intuition for. What are implications of this model for messaging? Public health messages that really stress how widespread HIV is. In other words, public health messages saying, tons of people are infected. If you have unsafe sex, that person probably has HIV. If you have unsafe sex, you're probably going to get HIV. That's going to increase R in the model. And if we think this nothing to lose effect is an empirically valid issue, this could be counterproductive. Because the scare tactic could make people almost give up and be like, well, I'm definitely infected. I've got nothing to lose at this point. So that's the sort of counterintuitive issue that sort of was rarely raised when information campaigns started. Yeah?
So this model only takes into account the likelihood of being infected, but it seems like what this is people's perception in terms of treatment. Like we're taking for given people know they're treatment.
Yes.
So like 5 years ago, someone had a person say, you're having sex with a
Yeah.
or having sex to take a shower.
Right.
So I'm wondering how that works.
That'll be one of our extensions. So one of the extensions here is going to be what happens when like ARVs are introduced or people think there's treatment. And I should have said this up front, and thanks for clarifying this. Think of this here as a world with minimal access to ARVs. And now that's changed a lot in the last 10 years. So in a couple slides we're going to talk through the thought experiment of what happens when you have ARVs and how is that going to change policy. So thanks for clarifying that. Let's put ourselves in the 1980 to 2003 world where you didn't have access to ARVs. There's another hand up.
I'm just wondering if there's been a study on the people having nothing to lose approach. Are they still being public with whoever they're partnering up with, and that other person also says, well, that's okay because I'm HIV positive and going forward from there, or are they or has it been a disguising factor?
I think it's probably too hard to characterize generally, and there's certainly some probably matching of people that goes on where people are very open to say that they're both positive, and there's some sharing of test results. I think within a particular relationship there'll be very different norms. Like if we just introspect or think about the people we know, our own life experience, there's very different types of information that is shared or verifiability of these kinds of things. Yeah.
And there's different types of HIV, so becoming positive, we're not supposed to sleep with HIV.
Right. That's right. So if you get a different strain of the virus, then that can really affect you. Even if that's right. So it's more complicated than even being infected in some sense. Okay. So we got to it. Next slide. So this is the question: what happens when you boost ARV treatment in the model? So what's the immediate thing that's going to happen when you boost ARV treatment? What variable is going to change? Yeah, so PHIV now is going to go up. And when PHIV goes up, the difference between P and PHIV goes down. So what sort of tendency would we expect to see in terms of the likelihood of unsafe sex when ARVs roll out? It's going to go up because now the cost has gone down. And this is very intuitive. And again, we talked a little bit last time briefly about some of the public health work that's been done in areas where ARVs have been introduced and the evidence that there is more unsafe sex. In fact, there's another student who's just finishing her PhD here at Berkeley this year named Willa Friedman. And Willa, her job market paper, looks at the rollout of ARVs in East Africa and got very detailed clinic level data, geocoded, on all of the clinics and at the very local level, and she got data for Kenya, Uganda, Rwanda, on the spread of ARVs. And then she matches them up to these surveys I told you about last time, these demographic and health surveys, and looks for evidence of unsafe sex or unprotected sex in areas where ARVs have been rolled out locally and areas where they haven't. And she finds self-reported unsafe sex goes up after ARVs are rolled out within 8 kilometers or 5 kilometers of you, and teenage pregnancies go up, which you might think of as unprotected sex or risky sex, although not in all cases. Some of that could be intended, some not. So anyway, there's some evidence in this setting that when ARVs roll out, people are taking more risks. And in this model, it makes perfect sense. That's exactly what this model would predict. Okay, so we already made this point, increases PHIV in the model. But the interesting thing is both of these interventions, and of course, the rollout of ARVs, let me just be totally clear, is saving millions of people's lives right now. And presumably we're willing, as a world community, these societies are very happy to have a little bit more unsafe sex in exchange for saving millions of lives. It's sort of a no-brainer. And by talking about these countervailing behavioral effects, in no way does that reduce the impact and the importance of these interventions. But it is important to understand what they may be doing to the epidemic. Yeah.
Also, with ARV, you're thinking of this other else looking at that, not else.
That's right. And so Willa, in her paper, writes down models, epidemiological models. If you guys are interested in this, these are both really interesting papers. This paper is now forthcoming in a journal called the Economic Journal, EJ. Willa is just finishing her dissertation. But Willa, and they both have nice epidemiological models in them, Willa works out that issue. She tries to get some estimates from the public health literature about how much transmission risk falls if folks are on ARVs, and says, now we have two effects in terms of the spread. ARVs are out there, so people are going to engage in more risky sex because of this logic. But at the same time, they're less infectious, essentially. So what are the kind of countervailing effects of the spread of the epidemic? And it really depends on the assumptions you make about what's going to happen to the epidemic. But there's a lot of interesting epidemiology here. But there are a number of studies now showing evidence that even though these nothing to lose effects are not at all attractive things to think about in terms of the nature of human behavior, they've come out in multiple studies in the US, in sub-Saharan Africa, elsewhere. So there's something about people, when they're protected from harm, taking more risks. I mean, that's basically what this is. Okay, what is the model missing? And the obvious one is lack of modeling of altruism. This is just a basic point, and we can model this in a lot of different ways. But I think that the most natural way to model, or one way to model, is to say, maybe that benefit of unsafe sex, S, is a function of my own perception of my infection risk, R. That seems to make sense. And you would imagine that, so what's the slope of S of R? Is it upward sloping or downward sloping? The benefits of unsafe sex, do they increase or decrease when I think I'm infected? Well, let's assume everybody has at least some altruism. Negative relationships. If I think I'm really infected, I'm not going to feel too good about having unsafe sex with somebody else. Now we get this offsetting effect. And this is where functional form is going to be very important. We can write a model. This is true of thought experiments in economics all the time. You can write a model to get either effect dominating. I can say, well, maybe the slope of SR is very shallow, so the nothing to lose effect is still much stronger than it. Or maybe this is really steep, and it's incredibly costly for me in terms of my own disutility to have unsafe sex if I know I'm infected. So those are the kinds of things that you would want to understand empirically. But this is what the model would look like. So let's take one functional form. Let's assume that S of R is linear, and it's just S equals, and this is a terrible abuse of notation, you'll have to forgive me, is S times 1 minus R. That's what that right-hand side means. So I used S here to mean different things. S is a function on the left-hand side. It's a constant over there. I put S and I put something in parentheses above, and then it's really multiplied. So yeah, this is like a total disaster. So just look at S times 1 minus R. Forget everything else. That's what we're going to focus on. Linear decreasing function. S is a linearly decreasing function of R. And if you just go through the algebra, it's actually pretty straightforward. Now we have, instead of S over here in the back, we have S times 1 minus R, and we get this very simple. I chose this so we get sort of simple algebra. But 1 minus R is going to be really critical here. Okay, so here, the way it's modeled, I'm giving away the answer. The way it's modeled here linearly, which effect dominates? How fast could you read what I put up and took down? This is the same expression we had before, multiplied by a constant, 1 minus R. So there's actually ways to model it. If you do this linear form, the nothing to lose effect and the altruism effect cancel out, and we're back in the world we were in initially. You see that? As long as R is between 0 and 1, it's not 0 or 1, but anything in between 0 and 1, this inequality is the same as what we had before. But it's very simple to have the altruism effect be more important. For instance, if we take a quadratic functional form. Then if you solve this, you'll see the altruism effect is going to dominate. We can pick any functional form. So, at the end of the day, because there's sort of ambiguity, theoretically, it makes this a very interesting quantity to try to test in research. And that's really the motivation behind Eric and Willa's work, is to try to find settings where they can test this. Say, which of these effects is dominating among which groups and when? And there's at least some evidence that the nothing to lose effect is meaningful in some contexts. Let me pause for a second. Any questions on the model, the framework? What else is this model missing? I want to go through 3 or 4 other things that are sort of obviously missing. Some of these have been hinted at. Yeah. That's right. So even if mortality risk falls tremendously, there could be just tons of personal costs, side effects, medical expenditures, checkups, constant visits, stigma. So there could still be a very heavy cost that isn't really being modeled here. Okay, so that's one. What's another one that this model's missing? Yeah. Yeah, that's pretty interesting. So this point about if you give people testing and they had tons of unsafe sex and they find they're negative, in this model, the way we were thinking about it is I had tons of unsafe sex, I'm probably infected. Now I found out I'm HIV negative. Okay, I'm going to be really safe. That's what this model says. They can learn, though, wait, I can have tons of unsafe sex and stay negative. This is great. So, so I think there's a learning process about this sort of relationship between unsafe sex and infection risk that the testing is going to lead people to update. And that's not in the model here at all, but that's a more sophisticated view of the world. Yeah. That's right. If we think people are making decisions about sexual partners not based on this long-term calculus of cost and benefits, then this model wouldn't necessarily work. And I know that's far-fetched, but it's possible. Some people may be irrational when it comes to love. We frown on that in economics. We don't put much stock in those rumors and legends. Of course, people are making decisions for a million reasons. People lose control. People do things they regret. People, people also drink and make decisions when they're drunk or when they're on drugs. Seriously, and that's a huge cause of unwanted pregnancy, for instance. So, so there's a lot of points at which this uber rational framework breaks down. Yeah. Exactly. So we touched on it last time. It's going to be one of my bullet points. Coerced sex is outside this model. To the extent that people are being pressured or forced into having sex, then these kinds of cost-benefit calculations are out the window, and there's a whole other set of considerations. So let's go through some of these. Not all sexual choices are voluntary. So rape has to be part of the story. It's a first-order issue. In the DHS surveys, there's data about domestic violence, there's data about sexual abuse, etc., and very large fractions of women in sub-Saharan Africa report that this is something they've experienced. So this is not a minor issue. This is a major issue that's outside of the model. Maybe there's sociocultural norms, and that's not just true in sub-Saharan Africa. There are cultural norms about sex in the U.S. and in every other society about what's acceptable and unacceptable that are affecting things here. Maybe in some communities, condom use is seen as being it's frowned upon. It's not something that's appropriate. Maybe other types of sexual behaviors are encouraged or discouraged, and that has nothing to do necessarily with HIV risk. But we're talking about putting other terms in the utility function other than what I've talked about. Or another way of thinking about that is maybe all these other sociocultural norms affect what S looks like and sort of how acceptable unsafe sex is or safe sex is. There may still be pockets of poor information. Someone mentioned the South Africa case. Even if people know overall that unsafe sex could lead to HIV infection, maybe they think that particular types of sexual activity are much more or much less risky. Maybe they think there are certain things they can do to minimize risk that are inaccurate. So even if the survey says yes, people know unsafe sex leads to HIV infection, they may not get all the details right, and that could be very important. What other factors beyond these should we think about? Yeah.
I was just saying, last summer for work, in Kenya, I saw an advertisement for a preacher who was claiming to cure HIV. This was last summer, so people must believe that put it as a stat.
A friend of mine who was like one of our lead enumerators for the deworming project left the NGO and is now a preacher going around Kenya claiming to heal people of HIV. A friend of ours. So it happens. Okay, let's go on next time.